All right then. So I'm going to go ahead and introduce the third session. So for that, we have on board Dr. King, Dr. Jennifer King. She's going to talk about Vault Prolapse and how I do it. That is more like her style of how she does it. She is the queen of urogynecology at present, so regal in her skill and conduct. We absolutely cannot wait to meet her finally. And this session is going to be chaired by our in-house wizard, Dr. Hebbar, the man who thinks on his feet like no other, and the much adored Dr. Hebbar. Also to conduct this session, let's have on screen Dr. Keerthi and Dr. Shravya.
Okay. Are you all hearing? Okay. Can we have today I wanted to talk about a slightly more complex case of recurrent vault prolapse. So do you have the next slide there? This is a lady who's had several operations in the past. She's 72 years old, which isn't considered elderly in our population. She's had a previous vaginal hysterectomy with an anterior and posterior repair 25 years ago, so about the time of menopause. Now that failed and she had quite marked prolapse. She had an intraperitoneal high uterosacral ligament plication 10 years later, so 15 years ago. This is a procedure popularized by Dr. Shull from the US and is quite a complex operation. Unfortunately, it also failed. So for the last 5 years, she's been having multiple different pessaries. And as you can see, they're causing ulceration or they fall out. So she's really very miserable. Let's have the next slide, please. Now, when she came to us, she had bleeding from her prolapse, but more importantly, she was aware of difficulty voiding. And when we checked, she had big residual urine volumes, 500 or 600 mils. She'd also presented, her GP had picked up that she had impaired renal function, which was quite new. And on ultrasound, she had bilateral hydronephrosis with dilated ureters, the full length of the ureter. When we pushed her prolapse back, she had copious leakage. Now, this lady's home situation was a little bit difficult. She was caring for her husband, who was an invalid, and he also had quite aggressive dementia. They'd been unable to keep any home help, so she was basically managing on her own. As well as the impaired renal function, she had a few other health issues. Main one was pulmonary fibrosis, so she did tend to get short of breath quite easily, and she couldn't lie flat. She had to sleep sitting up on lots of pillows. Go to the next slide, please. So I wanted to take you through how we might approach this lady. Recurrent prolapse, she's failed 2 standard procedures which really should have worked. So she obviously has very poor tissues. Now, she is elderly with a few health issues, but she has to be active. There's no one else to care for her husband. She is still driving. She still does the shopping. She looks after the house. Now, we're pretty sure this sudden increase or decrease in her renal function is secondary to the prolapse, to the ureteric compression, and also to her urethral kinking. So if we do nothing for her, she will die. And that really isn't an option. So we have to get her fit for surgery and fit for anaesthesia. And this operation has to work, doesn't it? We have to be able to get her mobile again, back home, and have this operation work. We cannot afford another failure. This is not someone we can operate on again. And I suppose the other thing to think about is when we reduced her prolapse, she had a lot of incontinence. So do we need to be looking at something to do with her for her occult stress incontinence? Next slide, please. So we decided that we would operate vaginally. because she certainly couldn't tolerate the increased intra-abdominal pressure from any laparoscopic type procedure, and she really wasn't well enough to have an open abdominal procedure. It was difficult because she couldn't tolerate a general, so we had to operate under a spinal block, which was really quite effective. And we had to operate with her basically sitting up, so we were down on the floor quite a bit. Now, what we did in this lady, we've opened up the vault, right? We've peeled back the epithelium, and here is basically the bladder and the peritoneum coming down. Next page, next slide, please. So what we then did was a standard bilateral sacrospinous ligament fixation. And you can see here, we've got 2 sutures on either side of the sacrospinous ligament. We've also identified what is left of the uterosacral ligaments. They're very stretched, but there's still something substantial there. Next slide. So what we did was place a strip of mesh. Now, you could use anything. This was cut from a flat mesh, but you could use, as I saw in one of the previous videos, what may have been the introduction, you could take a piece of a transobturator sling, for example, or any sort of midurethral sling, and attach it. So what we've done, we've anchored it to some tissue at the vault, which was basically sort of all we could find, and to the uterosacral ligaments. And we've done this with a permanent suture with a 2O proline. Next slide, please. Next slide, please. Then what we've done, we've taken those sacrospinous sutures and we've taken them to either end of the mesh. So one each side, to the ends of that mesh, which is about 12 or 13 centimetres long. Next slide. We've also picked up a little bit of the epithelium at the vault, as well as another bite into the uterosacral ligaments. And we tie those back. When you take those back, it's just like any other sacrospinous ligament fixation. It takes your vault back. Now, the other useful thing here is that very often it's hard to identify a vault, and you might have much more posterior prolapse than anterior prolapse. You can reposition your vault. You can essentially make a new vault so you've got relatively even anterior and posterior walls to take back to the sacrospinous ligaments. I think that's all we've got on there. Next slide, please. What we've done then is, as you would do with any sacrospinous, we make sure we haven't kinked the ureters. We do a rectal examination. Now, I think Dr. Matthews was making the point before, if you're using the cervix and you have to do a unilateral fixation because you can't take both sides of your cervix to the sacrospinous ligaments. With this mesh strip, you can, of course. And when you do a rectal examination, you will feel the mesh strips going down the side of the rectum, but it's not enough to compress the rectum. And then we did fascial repair. In this lady, in fact, we also added some anterior wall mesh because she wasn't particularly worried. And the point I'd make, which I'm sure you've already gathered, is that you could do this as a hysteropexy. You could take that mesh strip to the posterior cervix and the uterosacrals. Or, as Dr. Matthews showed, we could do it anteriorly. In this case, we just had the vault to deal with, and it was a recurrent vault failure. So our mesh was to reinforce things. Next slide, please. Okay. Questions? Will I take this down? Hello.
Yeah, I know your name is King, but actually
yes.
I felt you are the Queen.
Yeah. That was the right thing to
I also have read a lot about you, and you're one of the leading urogynecologists in Australia. You are the chairperson of Urogynecology Society for Australia, and I also heard about you, your FM talks, and your concern about the mesh and the government telling some restriction about the mesh usage, but you feel that the women of this era are losing the golden opportunity, because many of the things, like if you have to do without the mesh, what about those recurrences and recurrent failures? Anyway, I feel like your endeavor, to keep the mesh alive, okay, it will go on, and I think the women of this era will be definitely benefited with that. Okay. So coming to this particular patient, like who had a high uterosacral suspension, do you think in Australia it's the commonly performed procedure now also, and how many cases? Like, what's your personal experience?
Look, I would much more commonly do an extraperitoneal uterosacral suspension. The intraperitoneal, in experienced hands, is very good. If you look at Dr. Shaw's work, he has less than 1% ureteric kinking. However, the literature overall suggests up to 10% of ureteric damage or kinking with the intraperitoneal approach. You do need to be a very experienced surgeon. I think the extraperitoneal approach is simpler and definitely safer. Our problem is that the uterosacrals are probably essential to the development of prolapse. There's some evidence that people who develop apical prolapse relatively early or repeatedly start with slightly longer uterosacral ligaments. So they may not even be particularly lax, but they're already that bit elongated. So any of the procedures we do relying on the tissue of the uterosacral itself is perhaps not as good as with a mesh reinforcement. So yes, I think you try all of these procedures, particularly, as you said, given the climate with mesh. In this patient, she had failed what should have worked for her, basically. So we need to look at something else. And I think this is where, as you mentioned, very much where we need mesh. And maybe we don't need to use a lot of mesh, but we need something for this lady.
You're right. Properly performed surgery, uterosacral high suspension intraperitoneally, has the success rate of around 80 to 90%. But I don't know why it got failed in this particular patient. And as you rightly said, it has been associated with very high incidence of ureteric injury, kinking. And especially, I think the lower stitches, you have to be more careful, because the higher one, I think they are very far away from the real ureters. Keeping this mind of 10% complication rate of ureteric injuries, like, I really don't know, like, what are the medical legal issues related to this. But maybe that, like, you have to make it a point that you have to perform a cystoscopy, and you have to make sure that both the ureteric openings are draining the urine before you come off the OT. And
absolutely,
yeah, you are right. And here in India also, many old women who are having a lot of morbidity, you are using many times the pessaries. But many times the pessary works when the uterus is intact. But in the isolated case of vault prolapse, most of the time it doesn't act that good. Maybe that they have got already damaged levator muscles, and pessary is not able to stay above that.
I think you're definitely right, yes. Yeah. And we do have evidence that for significant prolapse, certainly in Australia, less than 30% of women can use a pessary long term. You might try it, and it often helps the patient decide, okay, I give up, I need another operation, this isn't going to work for me. And I think that's good. It also gives her an idea, if it works, how much can we achieve with a pessary? Because if you've got a successful pessary, that's about as good as we're going to get with surgery too. So they don't have such unrealistic expectations. In this lady with a massive proxodenture, I would not have persevered for 5 years with pessaries. I think you're quite right. The introitus, the genital hiatus was so poor, nothing was going to work.
And you said that your patient had a moderate hydroureteronephrosis. Do you ask for ureteric stenting prior to you post her for surgery by your urologist friend?
Well, we do it ourselves. If we're concerned, we will often stent the ureters preoperatively. Now, if there's a lot of scarring, even with the stenting, it can be difficult to feel. The other point I'd like to make for other people, I remember the very first case I had of a patient who presented to us with hydronephrosis secondary to prolapse. She'd been picked up with acute renal failure as her presenting feature. We did the operation really well. We checked that the ureters were working. it took 6 months for that hydronephrosis to settle. And I very foolishly thought, let's do another ultrasound a few weeks later, and was horrified to find that they'd barely improved. And you think your operation has failed, but it does take a long time. So please don't make the mistake I did. Don't go looking at the ureters too soon. If they're working and her renal function improves, be happy.
Yeah. So are you using any special instrument for suture pass through the sacrospinous ligament in the previous?
Look, I do. Yeah, I use the Capio suture. I'm comfortable with it. But I realise we're very spoiled to have it. And I was in Chennai a couple of years ago, and they'd arranged a few cases for me, and I thought, fine. But no, we didn't have the Capio. So I suddenly had to remember how to do what you do all the time and find that ligament without any help and exposing it. Fortunately, I remembered, but yeah, no, the Capio makes our life easier, but I know not everyone has it.
Yeah. Have you experienced any complications such as injury to the viscera or to the pudendal nerve and artery when you're using this special instrument?
Look, you're right. I think the most important thing is to know your anatomy and be very, very careful with your technique. And if you've got a reasonable amount of space, I mean, I can get one hand down, 2 fingers on the ligament, and I'll put the Capio right beside it. So I think if you're very strict with your trainees when you teach them and you really do know your anatomy. It's quite a small little needle. It's actually relatively hard to hook onto something else.
Okay.
Yeah.
Okay, one more question for you, Dr. Jennifer King. In India, most of the time, we are used to doing the unilateral fixation because, and most of the time it is on the right side.
Yes.
Because bilateral fixation, because we find it that it fans out the vagina too much laterally, and sometimes like it over tightens the posterior vaginal wall. And whenever one of the vaginal wall is tightened, that anterior defects becomes more post-operatively. And like you all know that when the anterior vaginal wall is too much tightened, then they will develop entrosy. So yeah, what's your experience with development of anterior vaginal defect with high bilateral suspension?
Okay, you are quite right, except when I do a bilateral, and I would almost always do a bilateral sacrospinous ligament fixation unless it was a very narrow vault, in which case we would do unilateral. But I don't use the cervix for anchoring. I actually use the uterosacral. So I use that retroperitoneal approach to the uterosacrals, and I take those down to the sacrospinous ligament. So then you don't have as much pressure and as much traction on the anterior wall. I agree, I still get some recurrent cystoceles, and it's very depressing, isn't it, even when you warn them. But I think the anterior approach that Dr. Matthews showed may well be useful in those ladies if they're predominantly anterior weakness. But if you have a wide vault, you've got a very lax vagina, don't try and attach the cervix. Actually bite into the uterosacrals and you'll get a much wider attachment with less traction on the anterior wall. Look, every patient you look at and you judge slightly differently, don't you? You do it all that little bit differently, depending on their circumstances. So just be prepared. Each time you go in, this is a little bit different. How can I best attach here? Yeah, as we all do. I did see one other question. Oh, sorry.
Yeah, we'll take the question from the other, I think the audience.
Mm-hmm.
Dr. Keerthi, have you collected a question from the audience?
Yes, sir.
Keerthi, so we are little running short of time, actually.
Okay, you can take it later then.
Maybe one question is okay?
Yeah. Okay, ma'am. Okay, ma'am.
I want to just request Dr. Jenny, Dr. Catherine, if she is there, and Dr. Douglas, Dr. Murli sir, Hebbar sir, and Priya ma'am, all of you to be with us for the town hall session as well, because we need your inputs there. We are going to discuss some interesting cases. Yeah, Keerthi, please go ahead.
There is a question from Dr. Kazila. She's asking, what specific brand mesh is used in Australia?
Look, we have, well, next week we'll only have one brand of mesh, which is Boston Scientific. We hope Johnson & Johnson and Coloplast have basically decided that the regulations in Australia are so strict, they're not going to try and comply with them. So Boston Scientific is the one we will have in the future.
Okay.
It's a bit
Okay.
grim.
Shall I ask one more question, ma'am? Like,
Okay, go ahead. Quick question.
Quick grip.
like they asked, like, what is the incidence of erosion with the mesh usage?
In your experience.
Look, it's actually very, very low. And if you think about it, because it's at the vault, you can bunch up that epithelium over it. Very, very minimal rates when you just use it across the vault. Obviously on the anterior wall where you've got a much larger area of mesh, your rates do run up to 10%. And that's what I would quote our patients with anterior wall mesh. Having said that, it is frequently very minor. Literally grab it with your forceps and snip it. Right? I think if you warn your patients that this can happen and that you can deal with it for them, it's not such an issue. Most of the fuss comes when nobody was prepared for it. If they're not sexually active, I'd probably leave it if it wasn't bleeding. So, you know, you don't have to fuss too much about a bit of mesh erosion in a well-counselled patient.
I think this is very important. Yeah, so can we wind up this session? I think it was a beautiful discussion. Thank you, Dr. Jenny. Thank you, Hebbar sir. Want to say something? I think we can just go to Suvriti, and Suvriti will lead us to town hall now. I think it is going to be an interesting, and I thank you all again on behalf of Team MUG.